one of the first studies that showed that CAR-Ts were effective in any disease were in fact in CLL, coming out from the University of Pennsylvania group. And along the way, we have had, there's really no doubt that for the right patient with CLL, the CAR-T therapy is potentially curative. But along the way, the CAR-T options in CLL has really lost steam for a number of different reasons. Firstly, the markets for relapsed diffuse large B-cell lymphoma and refractory acute lymphoblastic leukemia diseases, these are diseases which had much fewer treatment options and were much more attractive markets for the CAR-T cell developers. So much of the attention had been focused away on diffuse large B-cell lymphoma and acute lymphoblastic leukemia, where in most jurisdictions, CAR-T is now a recognized treatment option. So at the same time, as more and more CLL patients came to be treated with CAR-T, the results didn't look quite as good as initial, with a low rate of complete remission and a high rate of failure. Now, a lot of these relate to the material that we make the CAR-Ts from, because CLL patients, often by the time they come to cellular therapy, we have been through many rounds of chemoimmunotherapy. We've had probably a BTK inhibitor and a BCL2 inhibitor. And really, their immune system, by the time they come to CAR-Ts, are completely shattered by both the leukemia and the previous therapies. And it's very hard to collect quality T cells in these patients to make CAR-T cells from. So it's really not surprising that the CAR-T cells do not work well in patients with CLL when used as last-line therapy. Now, there are several improvement. Several companies are now starting to realize that, in fact, that CLL is not solved. That there are patients who are now developing resistance to both BTK inhibitor and BCL2 therapies, and therefore are in need of a cellular treatment option like CAR-T cells. And secondly, there is increasing evidence, and this is pioneered by the Seattle group, amongst others, that if you give ibrutinib around the time of CAR-T cell treatment, so both to facilitate the collection of good T cells, because we know that ibrutinib has a potential to suppress the CLL and improve the T cell profile, as well as to give ibrutinib around the time of CAR-T cell infusion and after CAR-T cell infusion to suppress the leukemia, that they may in fact improve the outcomes. So there are clues that combining novel agents in CAR-T cells may in fact improve the outcome of CAR-T cell therapy. Now, there are drawbacks to this. For example, there are anecdotal reports of patients who get ibrutinib and have a CAR-T cell infusion and then get really quite nasty arrhythmias around the time of cytokine release syndrome, because both the cytokine release syndrome and ibrutinib are potentially arrhythmogenic. However, nevertheless, there's now much attention paid to using BTK inhibitors and other drugs to improve the quality of the CAR-T cells collected from CLL patients. The other avenue of investigation is to essentially terminate the need for indefinite BTK inhibitor therapy and using CAR-T cells to consolidate an incomplete response in patients who otherwise are responding well to BTK therapy, but will be expected to be stuck on it long term. So that is also another active avenue of investigation right now.